I had the pleasure today to introduce our Grand Round speaker, who is Dr. Mouin Abdallah. Mouin joined us within the past year, and he comes to us from the Cleveland Clinic. Mouin has really a great background. He previously worked at Unity Health, where he was a chief medical informatics officer and a chief research officer, or the chief quality officer, excuse me, and then has his master's degrees in healthcare management and in clinical research. And he joined the clinic after his training at Mid-America Heart Institute. He was the medical director of the Coronary Artery Disease Center, and he was the co-director of the Center for Complex Coronary Intervention. And Mouin is a non-interventionalist, so he's a clinical cardiologist. And he also happens to be our our director for quality and safety in MHCM. And so has in his heart both the care of complex cardiovascular disease and doing it in the most high quality and safest way possible. And so the topic comes to us today because here at MHCM, we choose to differentiate ourselves from other programs in our region. And it's within our program that we really seek to bring together strategies for the care of patients with complex and difficult to treat abnormalities. And so Mouin will today talk to us about revascularization strategies for patients with multi-vessel disease, a topic which he knows extremely well from his time at the clinic, and now is helping us leverage for program advancement here at MHCM. Welcome, Mouin.
Thank you very much, Alan, for the nice introduction. Hello, everybody. I hope you can all see my screen with the introductory slide. I'm assuming that's correct, unless I hear otherwise from you guys. So for the next 45-50 minutes, I'm going to discuss with you revascularization strategies for patients with multi-vessel coronary artery disease. And part of this topic is a little bit controversial for cardiologists because so far, and this will come throughout the discussion, the trials that have been attempted to show the value of PCI in management of stable ischemic heart disease have not shown a mortality benefit, and I will address that in my talk. So these are my disclosures. As Dr. Taylor said, I do not perform PCI or CABG. I just attempted to understand the science behind all what we have done over the last 20, 30 years as cardiologists and how we can improve the care for our patients. So this is the outline of my talk. I'm going to start first by discussing the trials that compared OMT, or optimal medical therapy, and bypass surgery. And then I'm going to go on and discuss in detail some of the trials that compared bypass surgery to PCI. In fact, there are more than 80 of those trials over the last 20 years. We have extensively studied in randomized trials, CABG versus PCI. I'm going to then discuss the trials that compared medical therapy with PCI, and that's where some of the controversy about the value of PCI comes from. And then I'm going to present to you a heart team approach to revascularization, and then I'm going to show you my conclusion. I'm going to start first with a case, and I hope you guys can see the video when it's playing. This is a patient that I saw a couple of years ago. It shows severe LAD disease, and it also shows that the RCA is occluded, and as you guys can see here, it's filling from collaterals from the left side. And this is the circumflex artery that is also severely occluded. So in a summary, this patient has severe multi-vessel disease, 100% RCA, 90% LAD, and 90% circumflex disease. And then she was transferred to us for further management. This patient, and these are the revascularization options at this point. It's going to be bypass surgery, complete PCI, complete revascularization PCI, which means we'll fix the LAD at the circumflex and the RCA. We call it CTO, or chronic total occlusion. Or we do PCI of the LAD at the circumflex, do medical management only, or refer to some trial or research that is ongoing. And we'll discuss later what happened in details with this case. So starting with the trials comparing medical therapy and bypass surgery. We first knew that bypass surgery is a great procedure to help patients with obstructive coronary artery disease back in the 60s, but from René Favaloro from the Cleveland Clinic, when he started mastering the technique for revascularization. It wasn't until 15 years later, around 20 years later, when they had the CAS trial published, which compared patients with bypass surgery to medical therapy. This is the most commonly cited trial that was attempted back in the 70s, from 75 to 79. Around 800 patients were randomized to either bypass surgery or medical therapy. At that time, we didn't have enough evidence that bypass surgery does help patients or improve mortality. And this is the result of the CAS trial. It showed that really, when you look at everybody, there was no difference in CABG versus PCI. And this is the conclusion from the authors, suggesting that the accident survival rates observed among patients assigned to medical therapy or CABG, there was no difference between the two groups, support the conclusion that patients similar to those enrolled in this trial can safely defer bypass surgery until symptoms worsen to the point that surgical palliation is required. So even though the CAS trials is repeatedly being quoted as showing that evidence of bypass helps, it was not the primary endpoint of the trial itself. At the same time, a few years later, this was published from Loop and Lytle from the Cleveland Clinic, compared that among patients who are having bypass surgery, those that had the lima or the internal mammary artery used had a much better outcome compared to those that did not have the lima used. This was based on a registry analysis. This was not a randomized controlled trial. But this proved to us beyond doubt that the lima is important when performing bypass surgery. And we never looked back since then. Almost most bypass surgery right now has lima LAD graft done. In fact, it's one of the quality metrics. And at the MedStar here, we are more than 99% usage of the lima artery. What I'm trying to show you guys is that sometimes evidence might not be in the way you want it to be as a randomized controlled trial. There's no doubt in anybody's mind that the lima is a cornerstone for CABG. And to summarize all the trials that compared bypass surgery to medical therapy, this is a good graph. It shows the CAS trial, the VA study, and the European study, and a summarize of all the other trials. So about 2,000 patient totals were enrolled in trials back in the 90s and in the 70s and 80s, comparing CABG to PCI. And based on the totality of evidence, we probably are sure that CABG does improve mortality compared to medical therapy, even though the primary outcome of the CAS trial did not show us what we were trying to prove. So since then, cardiac surgeons never looked back and have been developing bypass surgery. At the same time, we had a lot of trials compared bypass to PCI, and PCI over the last 20 years evolved significantly. And at different times, we had a lot of trials. First, we were doing PCI using balloon angioplasty, which means we would go inside the blockage, inflate a balloon, and open up the blockage. We had no stents to put in at that point. And then we developed the stents, and then we developed newer stents. So I'm going to start first with CABG versus PTCA, which is only the balloon valvuloplasty. I'm going to give you a sample of only 4 trials, but there's a lot more than 4. A couple of years ago, I was invited to have a discussion with 2 cardiac surgeons about these CABG versus PCI discussions. And the question they kept going back to is that, why do we need a trial for each new stent type? That's because PCI keeps evolving, and as PCI evolves, the outcomes will change over time. And as you will see from the totality of evidence today, as much as the evidence evolved, there are some things that we know for sure. So we started doing PCI first in the 60s, started doing catheterization. Then 1979 is when we started doing PCI in stable coronary artery disease. At that point, PCI was only indicated for patients who have stable ischemic heart disease. It wasn't until 1983 when this group of cardiologists that were called the Cowboys from Kansas City Mid-America Heart Institute, where I spent some time of my training, and I, in fact, was in the cath lab with one person who published this, started doing PCI for patients who have acute coronary syndrome. This was a big voodoo back then, and the cardiology community did not directly accept this. They had very difficult time even publishing this, so that's why it was published in the American Heart Journal. Even though right now PCI for acute coronary syndrome is one of the most agreed upon and the most effective way to improve mortality in medicine. So beyond 1983, we started doing the trials comparing CABG with PCI, going back to stable ischemic heart disease. One of the big trials and important ones was the BARI trial, compared CABG to balloon valvuloplasty, published in 1996. And as you can see here, there was no difference in mortality between CABG and PCI at 6 years. There was no difference also in myocardial in mortality without myocardial infarction. So the BARI trial, also a subgroup analysis, showed us that compared to patients with diabetes mellitus, which you can see here, patients without diabetes mellitus had no difference in mortality in CABG versus PCI. And among patients with diabetes, they overall had a worse outcome compared to without diabetes, and CABG had an advantage compared to PCI. Now, this was not accepted as a full evidence back then in 1996. And you will see as I go throughout with the discussion today, we had to wait 20 years to have evidence and proof of the superiority of CABG to PCI among patients with diabetes mellitus. The BARI trial also showed us that compared to CABG, patients have a 50% chance of revascularization over 5 years after PCI, which is a big deal, and it affects patients' quality of life and outcomes significantly. So at that point, everybody wanted to reproduce the same design of the trial. So the British did their own version, the Germans did their own versions, and I think the Italians did another version. This is one of them called the ORBITA trial, comparing CABG to PCI. And as you can see, there's no difference in mortality between CABG versus PCI. GABI trial also had the same outcomes, and the CABRI trial, repeatedly, no real difference between CABG and PCI. So moving on to a new version of PCI, bare metal stents. At that point, they were not called bare metal stents because we only had stents. And the cardiologists felt great. We have now new developments, and we're going to improve superiority compared to CABG. So we had a lot of more trials comparing CABG with PCI. I'm going to discuss only 2 trials now. The SOS, or the stent or surgery trial, also showed that there's no difference in mortality between CABG and PCI by 3 years. Compared to CABG, PCI with a bare metal stent had significantly increased revascularization, around 25%. So for us as cardiologists, we had a major leap and advancement in the effectiveness of our therapy. We took revascularization from 50% to 25%. Still, we're not even close to what CABG does by 10%. The other trial around the same time, called the ARCH trial, also showed similar results. And I could go on for all the 80 trials comparing CABG and PCI. There's no difference in mortality among patients with multi-vessel disease comparing CABG to PCI. Also showed a similar pattern of results, showing that revascularization continues to be an issue post-PCI and not as much after CABG. And then in 2009, we had this very nice publication done, which they were able to collect individual patient data from 10 randomized trials comparing CABG to PCI. So this is not exactly like a meta-analysis. It's a step higher because you are comparing individual patient-level data. And they have about 8,000 patient total over the last 10-15 years prior to the publication of this paper, comparing CABG to PCI. And you can see here that probably there's a small advantage of CABG over PCI over long-term mortality up to 8 years, and myocardial infarction. And when they did the subgroup analysis based on diabetes, you see that in the category where there's in the patients that do not have diabetes, at 8 years, there's no difference in mortality between CABG and PCI. Now, this included drug-eluting stent and balloon angioplasty only. However, among patients who have diabetes, the event rate is significantly higher compared to patients that do not have diabetes. And CABG is definitely superior to PCI among patients that have diabetes mellitus. Still, even with this evidence in 2009, this was not considered as confirmatory evidence because it was not a randomized controlled trial. We had to do a dedicated trial among patients with diabetes mellitus to prove the superiority of CABG to PCI. Did we have to? It depends on who you ask, but the medical community, especially cardiologists, felt the need to proceed with the dedicated trials among patients with diabetes mellitus, and this will come later today. So fast forward to a drug-eluting stent. I'm going to discuss 2 trials mostly here, the Syntax and the Freedom trial. These are the most contemporary trials with a drug-eluting stent. I also want to say that these trials were done with the first generation drug-eluting stent. Now we are at a third and a fourth generation. We have bioabsorbable stents, but I'm not convinced that we need to repeat or replicate all those trials. So moving on to the Syntax trial, I'm going to spend a little bit more time on the Syntax and the Freedom trials because they are a lot more contemporary, and the stent technology have not advanced by a lot to change the quality of the evidence from here. It had a very limited exclusion criteria, so almost like an all-comer kind of trial, and randomized patients to either CABG or PCI with multi-vessel disease or left main disease, things that were felt to be only best treated with CABG at that point. The Syntax trial designed something called the Syntax score, which is an angiographic tool based on the characterization depending on the complexity of coronary artery disease, number of lesions, location of lesions, type of lesions. All those things would help us calculate a Syntax score. Now, I also want to say that since then, we have progressed and we have a Syntax 2 score and we have a Syntax 2 2020 coming up because the science keeps evolving. But the Syntax trial told us that based on the degree of obstructive coronary artery disease complexity, we might be able to differentiate which patients benefit from which therapy. So the Syntax trial published in 2013, and this shows us the outcome of the trial. Looking at MACE, which is major adverse cardiovascular events, at 5 years, CABG was superior to PCI with a 37.3 incidence of events rate after CABG, compared to 37.3 after PCI, compared to 26.9 after CABG. The gap or the superiority of CABG starts early on after therapy and continues to expand as time goes by. Now, again, this is major adverse cardiovascular events, which is a combined endpoint compared to what I was showing you earlier, focused mostly on mortality and revascularization and infarction. When you look at the endpoint from the Syntax trial, at all-cause mortality, there was no difference between CABG and PCI at 5 years, similar to the evidence that we were seeing before. There is probably a numerical tendency favoring CABG versus PCI, 13.9% versus 11.4%, but this was not statistically significant. But probably is true as time goes by that CABG is superior to PCI. When we look at repeat revascularization, we see that revas continues to be the challenge for PCI, even with a drug-eluting stent, 25.9% versus 13.7% after CABG. Now, back to the Syntax score, which I mentioned to you earlier. When you look at the totality of results by Syntax score, simply said by how complex is the coronary artery disease. Remember, these are all multi-vessel, including left main disease possibly. When you look at patients with low disease complexity or the Syntax score less than 23, we see that there's no difference between CABG and PCI by the endpoint of MACE at 5 years, 32.1% versus 28.6%. And when you look at the individual endpoints of the MACE, death, 10.1% versus 8.9%, stroke, which is one of the dreaded adverse events after bypass surgery, 4% versus 1.8%. It's not statistically significant, but it's numerically significant, and we all know that CABG is a higher risk for stroke compared to PCI. Revas continues to be a challenge, even in patients with low Syntax score, 16.9% versus 23%. And as you advance in the disease complexity, when you go to intermediate Syntax score, 23 and to 32, the CABG is definitely superior to PCI with a combined endpoint of MACE, 36.0% after PCI compared to 25.8%, and no difference in mortality. And when you go to patients with very high disease complexity, the gap between CABG and PCI continues to widen, 44% after PCI compared to 26.8%. We also see that mortality for the first time starts, we see a big difference between CABG versus PCI, 11.4% versus 19.2%, and this is also statistically significant. So among patients with very complex disease, CABG has a mortality advantage compared to PCI. It also has an advantage among all the other adverse events. compared to patients with intermediate or low complexity coronary artery disease. The SYNTAX trial also had a concomitant quality of life outcomes comparing CABG versus PCI, and this was published a few years ago and showed kind of what we know is that both CABG and PCI offers patient excellent relief from angina. And as you can see from, this is what we call as Seattle Angina Questionnaire, or the SAQ, developed by my mentor, John Spertus from Kansas City. Both therapies offer excellent therapy from angina, and the benefits are sustained over 5 years. However, at 5 years, because of the repeat revascularization, CABG is superior to PCI at that point. The SAQ, or the Seattle Angina Questionnaire, also told us that while patients recover quickly from PCI, within a month you see a big improvement after PCI. It takes between 6 months and 1 year to recover from bypass surgery, as you can see here by the SAQ physical limitation. However, by 1 year, patients feel much better after CABG. And because of the repeat revascularization and infarcts, at 5 years, patients physically even feel better after CABG compared to PCI. So you have a very fast recovery from PCI, slower recovery from CABG, but however, patients feel better after 5 years after bypass surgery. When we did look at quality of life outcomes by the SYNTAX score, or the disease complexity, we also see that patients are better after CABG compared to PCI if they have intermediate or high complexity coronary artery disease. And patients who have low level of complexity or low SYNTAX score do better after PCI. We have a similar results when we looked at the SF36, showing that it takes about a year to recover from bypass surgery, as what you would expect, and patients recover much quickly after PCI. And more data showing the same thing. The SYNTAX trial also had a cost effectiveness analysis, or an economic study, when we look at quality adjusted life years in addition to the cost of that study. And I will not discuss the details of the analysis we did here, but as we know, CABG is a little bit more expensive than PCI. And because of the repeat revascularization over 5 years, the gap in cost between CABG and PCI keeps diminishing over 5 years. And CABG offers a mortality advantage compared to PCI. So when you start calculating the quality adjusted life years, or the ISER, by year 4 and 5, you start seeing an advantage for CABG over PCI. And typically, this is how we look at cost effectiveness analysis. This is the line for the 50,000 per quality adjusted life year, which is the acceptable limit in the US that for which we are willing to cover therapy per quality adjusted life year. And CABG is superior to PCI and is a cost-effective analysis. This is for the totality of patients. When you look at the results by SYNTAX score, among patients with low disease complexity, the results are on the other end. So the results being here suggest that PCI is cost-saving compared to CABG, and PCI offers a superiority in quality-adjusted life years compared to CABG surgery. This means that PCI is dominant, so suggesting that you should always perform PCI among patients who have low disease complexity if you are only looking at the cost effectiveness of analysis. Among patients with intermediate or high SYNTAX score, the results are on the right of the green line, suggesting that CABG is cost effective. Moving on to the other trial I mentioned earlier, the FREEDOM trial. The FREEDOM trial was very similar to the SYNTAX trial. However, it only recruited patients who have diabetes mellitus. This was published in 2012. The BARI trial suggested in 1996 that CABG was superior to PCI among patients who have diabetes mellitus, but this was not accepted fully by everybody in the cardiology or cardiac surgery community till this trial was published in 2012, 20 years later. They only enrolled patients with diabetes mellitus and compared them over long term. And the primary outcome was MACE, and the primary outcome was after 5 years, 26.6% after PCI compared to 18.7% after bypass surgery. Statistically significant. When you look at all-cause mortality, 16.3%, 10.9% after CABG, P was 0.049. Even at that point, with this convincing evidence that CABG is superior to PCI among patients with diabetes mellitus, there were some naysayers who said that if you have one more event in the CABG arm or one less event in the PCI arm, P would not have been significant. And I'm just mentioning this because I want to bring out that sometimes the evidence is more than just a p-value. We knew 20 years before that CABG was superior to PCI. We didn't have to wait till 2012 to believe that or to prove that. When you plot the Kaplan-Meier curve over time, you see that there's an increased events early on after CABG surgery compared to a PCI, because we know it's a little bit riskier procedure. Between year 1 and 2, there's no major difference between bypass and PCI, but the gap starts widening and continues to widen over time. And by 5 years, there's more event rates after PCI than CABG among patients with diabetes mellitus. And this is the all-cause mortality, starts showing up by 2 years and keeps widening over time. So more recently, in 2018, they published the extended FREEDOM trial. So they looked beyond the 5 years, the duration of the trial, and showed that this gap in mortality continues to widen over time. Now, this was not statistically significant with a P of 0.07. However, again, what we can prove in trials and p-values is different than what we know. I think this just emphasizes that CABG is superior to PCI in terms of mortality. The FREEDOM trial also had a cost effectiveness or an economic sub-study, also showing that CABG is more expensive than PCI, and the gap continues to narrow over time because of the repeat revascularization after PCI. The mortality gain for CABG does not start showing up, as you can see from here to year 4, because of the early increased event rate immediately after CABG. And CABG does not start becoming cost-effective till year 5 after revascularization. And when we did the cost-effectiveness analysis here, as you can see from this graph, overall the event rate is a lot more to the right of the graph. This ISO curve of 50% per quality-adjusted life year. And when we did the subgroup analysis, even among patients with low syntax score or intermediate syntax score or high syntax score, CABG is a cost-effective and is the recommended therapy among patients with diabetes mellitus, with an ISO ranging from 3,000 for high syntax score to 20,000 for patients for low syntax score. The FREEDOM trial also had a quality of life or patient-reported outcomes analysis that was done simultaneously. It showed similar pattern of results as what we have seen before. Both interventions, PCI or CABG, offer significant improvement and treatment for angina. And by 5 years, CABG is superior to PCI with a small difference because of the repeat revascularization. Also showed us that it takes about a year to recover from CABG. Probably by 6 months, you start feeling significantly better. By 1 year, patients start feeling better after CABG compared to PCI. And there's no statistical significance by year 2 and 3, but by 5 years, patients do much better after bypass surgery compared to PCI. When we looked at the SAC or the Seattle Angina Questionnaire, the angina-free frequency, patients more likely were angina-free after bypass surgery compared to PCI, especially at year 1 and year 5, and those differences were statistically significant. More recently, this analysis was published looking at the FREEDOM trial by syntax score to see, does the syntax score matter among patients who have diabetes mellitus just like it did in the syntax trial. And it showed that irrespective of the syntax score among patients with diabetes mellitus, CABG is superior to PCI. So if you would compare both the blue lines here, that's the low syntax score. This is the outcomes after PCI, and this is the outcomes after CABG. Even among patients with low syntax score, patients do better with CABG compared to PCI. This is separate from the FREEDOM trial. This is a registry analysis. This is not a randomized trial. This is from Europe, from Denmark, looking at patients with diabetes mellitus type 1, because there were some suggestions that because of the different pathophysiology of disease in type 1 versus type 2, maybe we can perform, maybe PCI is okay with patients with type 1 versus type 2. And this also suggests that even among patients with type 1 diabetes and multi-vessel disease, the outcomes are better after bypass surgery versus PCI, and this is all-cause mortality. Again, this is a registry analysis. This is not a randomized trial. So moving on to trials comparing optimal medical therapy and PCI. And this is where there's a lot of controversy and a discussion and disagreement among cardiologists about, does really PCI help and improve mortality compared to medical therapy? And I'm going to focus on 3 trials: the CORDIS trial, the ORBITA trial, and also the ISCHEMIA trial. And I want to stress a point that the controversy within cardiology exists only among patients with stable ischemic heart disease. Among patients who have acute coronary syndrome, whether it's unSTEMI or STEMI, the mortality advantage of PCI is beyond doubt proven, and there's no disagreement or discussion among cardiologists. This controversy exists mostly among patients with mostly low risk and stable ischemic heart disease. And we have our own way of defining what is high risk by history, by findings, by ECG and cardiac markers. So moving on to the first major trial, the CORDIS trial, published around 10-15 years ago, compared patients with CAD to medical therapy and PCI, and they had multiple endpoints: all-cause mortality or infarction, survival-free of ACS. And as you can see, all different endpoints, there was no difference between medical therapy and PCI. And this has been a kind of a shock to cardiologists at that point, but we accepted this, and this has been included in our guidelines and our appropriate use criteria, that the mortality advantage for PCI compared to medical therapy might not be as easy to prove or as obvious as what we suspected. The CORDIS trial, shown by our own Dr. Weintraub, who is member of MedStar, also showed that PCI is superior to medical therapy in angina relief, and this was also incorporated in our guidelines, where we mostly perform PCI to relieve patient symptoms from angina. The advantage or the superiority of PCI diminishes over time and is not significant by 3 years. I only want to mention, there has been a lot of criticism for the CORDIS trial up front, but I only want to mention one thing. I don't want to discuss all the issues with the CORDIS trial because of the time limitations. The CORDIS trial screened 36,000 patients, out of which only 2,200 were included in the trial. So it's a very limited population that were included, and among those patients, that's where there was no mortality advantage of PCI compared to medical therapy. Moving on to another major trial published recently, which took a lot of attention. This was done in England, published 2 years ago. It was an ORBITA trial. This is a very interesting trial because they did sham PCI. So they took patients, randomized 230 patients at 5 hospitals in England. They had more than 70% obstructive coronary artery disease. They had medical therapy, and they were randomized to medical therapy versus PCI. So there was a sham catheterization involved, which means patient had a cath. Patients did not know if they had PCI or not, but they had the catheterization. And the endpoint was the difference in exercise at 6 weeks. Obviously, when this was published, this took a lot of publicity, and everybody started calling stents as useless. Now, this is the mainstream literature. Fake surgery exposes useless treatments. Heart stents are useless. They're still widely used. So PCI got a lot of negative publicity after this ORBITA trial was published. And these are the results of the ORBITA trial: PCI versus placebo, 90 patients versus 104. The increment in exercise was 11.8 minutes after placebo and 28.4 minutes after PCI. The difference was 16.6. Even though this is pretty high, it failed to reach statistical significance of 0.2. So it's important to understand how the trial was designed and implemented when you try to analyze results of such data. So they had about 200 patients that were randomly assigned. In the placebo arm, 4 patients underwent PCI for procedural complications. So when you have a very limited therapeutic margin and 5% of the placebo receives the intervention, it's very difficult to show evidence of effect of intervention. Now, those were included in the analysis because it's an intention to treat analysis. And 105 were in the PCI arm who did not receive PCI. Also important to understand that in the ORBITA trials, every patient had 1 to 3 phone calls per week with the cardiologist, which is very difficult to implement in the healthcare model in the US, where you have someone call you and make sure you're doing okay. These patients were on intensive hemodynamic observation, intensive anti-anginal regimen. The most important thing, I think, from the ORBITA trial is that once the trial finished, 85% of patients in the sham arm went and got PCI. To me, this meant that you can safely delay PCI in patients who have 70% single vessel disease, but I don't think you can cancel PCI for those patients. Now, this was not mentioned in the trial when it was published. This did not get any media attention. And this is what the authors of the trial told us, that as soon as we finished, we went and did PCI in all those patients. More issues noted within ORBITA trial is about 30% of patients did not have significant obstructive disease. It's very difficult to show that intervention will improve outcomes when the disease was not significant baseline. There was no significant disease. A 40% complication rate that I mentioned already, and 25% had no significant symptoms at baseline. Also, what I think is more important is that the choice of statistical test used in ORBITA, and this is between brackets, so this is verbatim what the authors said about the trial. So, and I'm going to read it because I think this is important. Criticism of our original plan to use the 2-sample t-test is entirely reasonable. Knowing what we know now, we agree it would have been better to specify ANCOVA. Nevertheless, the primary analysis has to be done in the way one pre-specifies. Rest assured, we will use ANCOVA for secondary analysis. So to translate this, when they were designing the trial, the cardiologist decided to use a 2-sample t-test. However, that was the wrong statistical test to use for such analysis. And they published the trial using the 2-sample t-test. After it was published, the statistician wrote to the editor suggesting that an ANCOVA is the correct test to use. And when you use an ANCOVA, the trial becomes a positive and not a negative trial. And this was the author's response after this was published. So to be fair to the science, I think to use an ANCOVA after ORBITA, it would be a positive trial, in addition to all the issues noted in the trial design itself. Moving on to the third trial, the third main one, and most contemporary is the ISCHEMIA trial. This was a publication from the patient baseline published in 2019. The ISCHEMIA trial tried to avoid the issues that were noted in the CORDISH trial and focus on patients who have significant level of ischemia at baseline to show whether PCI versus medical management helps. The ischemia trial was very challenging to undertake. It's a very expensive trial. It costs about $100 million to do. And they also had liberal inclusion criteria compared to the CORDISH trial. So the authors tried to do it as much as possible to match real life. However, even before the ischemia trial was published, as you can see from the headlines here, there were issues with the trial. The most important issue was low recruitment. Some cardiologists believe that PCI helps patients and improve mortalities, and they do not feel that referring patients for such a trial is warranted. So it was very difficult to enroll patients in this trial. So the authors or the research committee decided to change the endpoint halfway through. They also decided to change the number of patients needs to be enrolled. Otherwise, they would have never been able to complete the trial. And that created a lot of issues before the trial was published. Needless to say, the trial showed that Invasive therapy did not offer mortality advantage compared to conservative therapy, as you will see from the graphs shown here on all different endpoints, including all-cause mortality, the MACE, the primary endpoint, myocardial infarction, or death, or MI. When you look at the subgroup analysis, especially this one here, met ischemia eligibility criteria according to the core lab. It shows that among patients who were really ischemic compared to patients who really had no ischemia at baseline, there's probably a hint of a suggestion of an interaction there, that compared to patients who had no ischemia, medical therapy was better. And this is not statistically significant, but this is the main criticism for the COURAGE trial and also for ischemia trial, that probably PCI helps when you have ischemia. Now, we don't have a randomized controlled evidence to prove any of this, but I think the totality of evidence suggests that. As before, the ischemia trial also showed that the PCI is superior to medical therapy in terms of the level of angina and the patient-reported outcomes as measured by the SAC questionnaire that we mentioned earlier at the SAC and the FREEDOM trial. And this is also another suggestion that invasive therapy is superior to medical therapy in patient-reported outcomes. Still, there are a lot of criticism for the ischemia trial, and we're not here to prove or disprove the ischemia trial. So in summary, I, as a non-invasive cardiologist, I do not have a randomized controlled trial to prove to anybody that PCI improves mortality. However, I do believe there's a role of PCI in certain patients. And that's what I want to mention in the heart team approach. And I think we need a paradigm change. We don't need to think about coronary artery disease in this manner that we have been doing for the last 30 years. We started comparing medical therapy to CABG, medical therapy to PCI, PCI to bypass surgery, and we did more than 80 trials. This has been studied extensively over the last 30 years. I think this should be a better approach to therapy. Everybody should get medical therapy. And a select group of patients do better with PCI, and a select group of patients do better with CABG. And you need a team approach to decide who gets better with bypass surgery and who gets better with PCI. This has been our approach to revascularization for the last 30 years, where we hope that we have one answer that can apply to all of our patients. However, that's not how our patients exist. We don't have patients with different colors, meaning that whether they are harmed or benefited from therapy. I tell all my patients, if the risk is 1%, but happens to you, then it's 100%. And in fact, we have patients who are harmed by revascularizations, and we have patients who are benefited by revascularizations, and we have patients who have no advantage from revascularization. And it's our job as cardiologists, as surgeons, as interventionists to know who benefits from what. And this is how we need to report trials. We need to know who benefits and who is harmed by revascularization and who has no main advantage. And this heterogeneity in treatment response has been advocated by one of my mentors, John Spertus. And I think this is probably driven by the extent of ischemic burden. This is not a randomized controlled trial. However, this is looking at percentage ischemic myocardium and the effect of revascularization and the effect of medical therapy. And it shows among patients with low ischemic burden, probably, and I say probably because this is not a randomized controlled trial again, probably the risk of revascularization is higher than the risk of adverse cardiac events, and there's no benefit for revascularization in those patients. Among patients with high ischemic burden, probably the risk of adverse events with medical therapy is so high that revascularization is better. The patient that I showed you the catheterization for probably had a 50% ischemic burden and probably lies around here somewhere. This was published almost 20 years ago, and this was published last year by also one of my mentors, Tim Bateman from Kansas City, showing that probably between 5 and 10% is when you have a benefit for early revascularization compared to medical therapy. Just this week, or even just 2 days ago, this was published in The Lancet by a lot of big names in cardiology and cardiac surgery, including Dr. Farkou and Dr. Fuster, looking at patients from 4 different trials: the Syntax, Freedom, BEST, and Pre-Combat. These were 4 contemporary CABG versus PCI trials, and they looked also into details about the long-term outcomes of CABG versus PCI, and they were able to identify a pattern of which patients benefits how much from CABG versus PCI. And they came up with a new model that includes the Syntax score, in addition to a lot of other clinical factors. And this is just an example of having 3 different cases where patient number 1, for example, who is 74 years old, does not have diabetes, and has some kidney disease, would probably do better with PCI compared to CABG, with a 10-year risk of all-cause mortality of 68% and a major adverse cardiac events of 44 versus 30%. Patient 2, who is 60 years old, with diabetes, normal kidney function, and normal EF, probably has no major advantage of CABG versus PCI, and probably this should be a hard team approach, and patients should have a choice of therapy and to decide into a risk of stroke versus risk of revascularization. And patient 3 does much better with CABG versus PCI. So it's important to understand that our science and our prediction models continue to evolve over time, and there's no simple bracket or no simple criteria that defines CABG superior to PCI or PCI superior to CABG. For example, case 2, which is also a diabetic, probably has no major advantage from CABG compared to PCI. So in conclusion, it's important to send the correct message to our patients that we're not flipping a coin, we're not playing with them. It's not that you go see a surgeon, you end up with surgery, you end up seeing interventions, you end up seeing with a PCI. There's a wisdom and some science. This is one of the most heavily studied aspects of cardiology, is the revascularization. And it's important to send the correct message to everybody that optimal medical therapy is cornerstone and critical for every patient, irrespective of whether you want to revascularize, and also irrespective of the choice of revascularization. We as cardiologists look at a lot of different factors. If patient is not a good candidate for CABG for whatever reason, or for PCI, both of them are excellent options. We as cardiologists look at how good are my surgeons, or how good are the interventionists where I practice? How are the targets? Can we achieve complete revascularization? Do we have diffuse disease or focal disease? What is the patient compliance with dual antiplatelet therapy? What's the ejection fraction? Is there mitral regurgitation or not? Is there LAD disease or not? It's difficult to justify CABG among patients that do not have LAD disease and who will not have a limit LAD graft. What are other medical issues going on? All those things are part of our decision-making process, and they're not included in the simple summary of the trials. But a good cardiologist, a good interventionist would understand all those aspects and their impact on the outcome of the results. A simple summary of the results in big terms: if you have multi-vessel disease and diabetes, then prefer CABG. But as the example that I showed you, does not apply to everybody. If patients have multi-vessel disease without diabetes and complex disease, also favor CABG. If they have simple disease, then favor a heart team approach. If economics is an issue, like an HMO, then probably favor PCI as more cost-effective. Things to keep in mind is that optimal medical therapy keeps evolving over time. And in the last few years, we have newer cardiac medicines that are improving the outcomes of our patients. CABG continues to evolve, multi-arterial, DAPT or NOAC post-CABG. PCI continues to evolve also. And we also have possibly hybrid coronary revascularization, where a patient would have a Lima LAD and then would have a PCI of his other coronaries to achieve complete revascularization. It's also important to keep in mind that we have appropriate use criteria that guide our practice, and we always try to abide by this as much as we can. Even though our guidelines favor CABG over PCI, I'm not convinced the evidence is supportive of this for all our patients. Moving on to our case, so that patient was turned down for CABG because she had a malignancy, and she was stuck in a catch-22 because she could not get therapy for her cancer, and she kept being admitted to the hospital for heart failure, not for ACS. The interventionist denied PCI, and he told me that PCI has never been proven to improve mortality, and never ever, which he is true, but that was not correct for this patient. So I had two options: call ethics or find a different interventionist, which is what I did. The patient was referred for PCI, and of course, what we did is we did PCI of the LAD. We did not perform PCI on the RCA, which you'll see here, because I felt there's enough blood flow from the collaterals that there was no need to pursue complete revascularization and high-risk CTO PCI on the right. The circumflex also was PCI'd. The patient did great from cardiovascular perspective. Her ejection fraction went from 15% recurrent hospitalization for dyspnea and heart failure to 35%. She never had any cardiac issues till she passed away a year and a half later from sepsis, not from a cardiac problem. Before I performed PCI, I asked the patient, what do you want? She had teenage kids at home, and she said, I want to be home. I want to fight this cancer, but I'm not able to because my heart problem is in the way. And she got what she wanted. She spent a year and a half at home taking care of her kids after being denied PCI. I have a lot of cases that show a similar pattern where patients are turned down for PCI and CABG for whatever reasons, and then they get transferred to see me. This is another example where the patient had the right was occluded. She had severe left main disease going to the LAD and the circumflex, turned down for CABG, turned down for PCI, came to see me, and I sent the patient for a complex PCI where we did PCI the left main going down to the LAD and the circumflex. We did not aim for complete revascularization. We did not pursue the right coronary artery because it's a high-risk revascularization. This patient did much better and did not have any further cardiac issues for the next 2 years that I followed her. And at this point, I want to thank you again for your time. I want to give you some time for questions. I understand this is a very controversial topic, so I'm happy to listen to all feedback and questions. Thank you very much.